So, it's my pleasure to reintroduce Dr. Geraldine Leader. And Geraldine, of course, is a professor here at the NUI Galway. And she has put together a session called Preschool to School. And I'm not going to say anything more, but ask Geraldine to come forward and introduce the session and her companions up front.
Thank you. Thank you very much, Ian. So I'm delighted to welcome you again to our second session, our Theme 2, Preschool to School. And just before we begin the session, just to reiterate that this theme is a very important theme in doctorate research, and we all here are so well aware of the importance of effective and early intervention. And a lot of doctorate work has been devoted to that topic. So, for example, many of our assisted fellows conducted really impactful work in this theme. Just to mention a few, but not exclusively, just a quick few, Dr. Anita Yakundai modified a reading programme so that children with moderate to severe disabilities could access a reading programme in schools. Dr. Sean Gilroy designed an open source app to deliver the picture communication system PECS in the classroom. Pauline Frizzell developed an assessment of complex syntax for children with ASD and ID. Nigel Robb developed adaptive video games and multisensory stories for children with ID. And Dr. James Northridge reviewed communication apps for children with complex communication needs and developed a selection tool for parents and educators. And Dr. Brian Boyle developed a peer-mediated application for joint attention skills training. So really valuable work that has already been conducted by doctorate. So today in this session, we're going to be taking a more holistic view. Okay, so we're going to be looking at health and well-being for both the child and the family. So our first speaker today is Dr. Sharon Millberger. And as I said, Sharon will take a holistic approach in her talk, and it will explore issues related to health and well-being and how we can promote health and wellness for both the child and family. So just a few words to introduce Sharon. Sharon is Director of Michigan Developmental Disabilities Institute and is Associate Professor of Family Medicine and Public Health Science at Wayne University. Dr. Millberger is also Director of the Michigan Leadership Education in Neurodevelopmental and Other Developmental Disabilities. She earned her Doctorate of Science degree in Epidemiology from Harvard School of Public Health. Dr. Millberger has a deep commitment to serving children with developmental disabilities and their families. She has over 2 decades of research and program experience in childhood neurodevelopmental disorders, early intervention, family support and health promotion. So I'm delighted to welcome Sharon to the podium.
Good morning. I'm delighted to be here and very honored to be here with you this morning. And as Geraldine mentioned, I'm going to give a holistic, high-level overview of some of the challenges that children with intellectual disabilities and autism face around health and wellness and their families, to set the stage for hopefully will be an interesting dialogue in our workshop this afternoon. And I'm so glad that I came. This session is coming after the session on aging, because a lot of the things that I'll be talking about, this is really the time where you want to look at prevention as well as health promotion. So just very briefly, a little bit about myself and where I come from. I am the director of the Michigan Developmental Disabilities Institute at Wayne State University. And we are what's known as the University Center of Excellence on Developmental Disabilities, or a UCED, for those of you that are familiar with that terminology. We're part of a national network across the U.S., so every U.S. state and U.S. territory has at least one University Center for Excellence. So for the state of Michigan, the UCED is housed at Wayne State University, which is in Detroit, Michigan. Oh, and I should mention, when I heard this morning about the purpose, our mission for this entire network is to promote full community inclusion for individuals with developmental disabilities and promote quality of life. And that's for people with all types of disabilities and across the lifespan. I'm also one of the co-directors for the Michigan LEND program, which is the Leadership Education in Neurodevelopmental and Related Disabilities. And this is an interdisciplinary graduate level training program, also as part of that same US network. And that is to prepare future health professionals to address the needs of children and young adults with ID, autism, and other neurodevelopmental disabilities. And we have, can the hands raise of the LEND faculty that happen to be here today? Because this is a partnership with Michigan State University, as well as several other universities across the state of Michigan. And I just want to give a plug for Fiona and Jonathan, who are presenting next and will be at the dinner this evening. We met them through the Michigan LEND program. We were fortunate they were in Michigan last spring. So just to set the context, I want to talk about just a couple quick definitions. One is the definition of health. And this is an old definition from 1948 from the World Health Organization. And here, health is defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And wellness is a newer term. This is a definition I found from the National Wellness Institute. And it's defined as an active process through which people become aware of and make choices towards a more successful existence. And what I like about this definition is, there are a couple things I like about it. One, this idea of it being an active process. It's not merely one point in time, because we know that over the course of our lives, there can be different things that happen that can impact our well-being, but there's always the opportunity to optimize well-being. And this also brings in the idea of choices and behaviors, things that we can influence. And it's a holistic, the diagram here at the bottom just shows that it's a holistic approach. And that's really what I'm talking about here. So I'll be using health and wellness interchangeably here, but please keep in mind I'm talking about that holistic well-being and really something more aspirational. This is not just the absence of disease or just physical health, but it's really how do you optimize the opportunities for people, for all people to thrive and not just survive. And I think one of the things I have found, having worked both in the developmental disability field and outside of it wearing the health promotion hat, is outside of the disability world, people don't think about people with disabilities when they talk about health promotion and well-being. It's just, there's a very big disparity there. So I'm very excited to have this opportunity to be talking about research in this area. And the other piece here is that I think a lot of times in the developmental disability world, not so much with this group, but there is this tendency to focus on a medical model. And we know that with disability, this is a lifelong matter that people live with, and there should be every opportunity to optimize well-being. So I'll focus first on physical wellness, and there are three big buckets that I'll be focusing in on here. In getting regular physical activity, good nutrition, and adequate rest. And the speaker spoke about oral health. I won't be talking about that, but it's certainly a major issue. So why does this matter? The so what, or why does this matter? In terms of physical health and well-being, we know that there's an obesity epidemic across our world, across the globe, and that obesity epidemic is even more pronounced for individuals with intellectual disabilities as well as autism. So this is a study, these are statistics looking at the difference between with and without a developmental disability. So the prevalence in adolescents is about 13% compared to those with intellectual disability, which is almost 20%, and those with autism, it's 32%. And just bear in mind the statistic you heard this morning about the prevalence, that goes up to 80% in adults. So again, these things don't happen overnight. It's starting here, and this is where we need to be taking action. And then there are a whole host of secondary conditions related to obesity, so we want to get in before these happen. High blood pressure, liver and gallbladder problems, diabetes, high cholesterol, cancer, and then mental health issues as well, including depression, fatigue, low self-esteem. And what's very disturbing is that the research shows that this generation of children has a shorter life expectancy than their parents. This is the first time that this has happened where the newer generation will not have a longer life expectancy. So in terms of the physical areas of health, so we know that nutrition is very important. And we know that there are barriers to healthy eating in children with ID and autism. And the research shows, this is from a meta-analysis, and I'm going to try, in a lot of the studies that I have listed here are meta-analyses, just for the sake of time. Children with autism are 5 times more likely to have mealtime challenges, including very selective extreme food selectivity, ritualistic eating behaviors, tantrums, and one of the things we want to make sure is that mealtime doesn't become a war zone for families, so that we really want to be thinking about how do we overcome some of the barriers to healthy eating. In terms of physical activity, this is probably very hard for you to see, but there's a whole host of barriers that parents identify in their children for them being physical activity, engaging in physical activity, including poor motor skills, learning challenges, behavior problems. Physical activity can be overstimulating for some children. And one of the big issues is that the programs are often not accessible to children with ID and autism. There may be some social skills that limit participation in physical activity, particularly team activities, and then not having few friends, which makes it also can be a barrier to participation in physical activity. And then similarly, these are findings looking at how children report some of the barriers to physical activity participation. So all kids think participating in physical activity is a way to make friends, but significantly less so for kids with autism and intellectual developmental disabilities. There's a big difference in the preference of participating in physical activity in one's free time. So kids typically developing kids have a much higher preference to do physical activity in their free time. Good news is most kids find it fun. Again, less so for kids with autism. And then interestingly, typically developing kids, none of them said it's hard to learn, where it was about 16% in the kids with autism. And then similar difference in participating in team sports. So another big area for physical health is screen time. And the research shows that kids with autism they really like watching TV. All kids like watching TV, but it's really a significant difference in terms of high TV time use in the free time. So it's more than twice as high in kids with intellectual disabilities and autism. And then similarly, video game usage is also higher in kids with autism and intellectual disabilities compared to typically developing kids. There's a statistic, it's not on this slide, but showing that the use of screen time for social interaction, most of the kids with autism and ID are not using screen time for chatting and email. That's the majority, about 65% do not use it for any social interaction, which we know is very different than their typically developing peers. So these studies come from the National Longitudinal Transition Study, and what the research shows is that because technology is changing so quickly, it's really hard to get a good grip on the evidence base. And that some screen time can be good, and it depends on how you use it, and then how you limit it as well. So this is a link from the American Academy of Pediatrics. This is relatively new, and it's an interactive tool on how to create a family media use plan. And it's a really cool resource. I encourage you to check it out. It allows you to do a media time, it has a media time calculator, but it's not just screen time. It includes the amount of time in physical activity, sleeping, studying, things like that. So it's allowing a parent and families to keep track of how the child is spending their time. It has resources for doing, creating a family media pledge and some tips around that. The thing about this resource, though, is that it hasn't been looked at in terms of what kind of accommodations would need to be made for a child with an intellectual or developmental disability or autism. So I mentioned that I think that all screen time isn't necessarily a bad thing. So one of the opportunities, I think, is around gamification. So we want to meet children and families where they are, which is, as we know, often in front of their screens. So some of the work that I've done is around the 5210 message, which is a healthy lifestyle message that's put forward by the American Academy of Pediatrics. It's an evidence-based healthy habits message, and it's for simple daily lifestyle messages. So the 5 is around getting at least 5 servings of fruits and vegetables each day. The 2 is for limiting recreational screen time to no more than 2 hours a day. The 1 is for getting at least 1 hour of physical activity each day. And the 0 is for consuming 0 sugar added beverages. So we know that these are all big areas that are related to childhood obesity. So one of the things that is shown on here is an app that I worked on with a health system in Detroit called 5210 Kids. And that app focused on, it has a game, what's called a mini game, around each one of these lifestyle messages. And the app that was, this original app that was developed really wasn't focused on kids with disabilities, but I think there are lots of opportunities to make accommodations to make it more accessible to all children. But one of the things that is interesting with this particular app is how can you use a screen to decrease recreational screen time? So what we did in this particular app is it's a virtual board game, and there's virtual dice. You throw the virtual dice, and you move around a board. For those of you that know the game Candyland, I don't know if that's an American game, it might be. But you move along the board, and when you land on the space, it gives you an activity to do that takes you off the screen. And it might be like go take your dog for a walk, or help mom or dad with some chores or things, or read a book, do a puzzle, just things that take you off the screen, and then the child gets points for doing those. So currently, it's under working on it right now is a new app that's for slightly older kids. This first app was for gauged towards 4 to 7-year-olds. The new one is focusing in on 19 to 13-year-olds, and it uses augmented reality. Again, the technology keeps changing, so you got to keep up. And that, for example, with the 5 game, it uses augmented reality, and you hold the device, you walk around and you pick fruits or vegetables, you walk around the room and you pick them, and if you get points if you do that, and you get rewarded. And then if you pick the pizza or the chips, it doesn't like that, it gives you bad noise. And so it's a very fun way of doing it. I am not going to talk about sleep because you're going to hear about sleep next, but what I wanted to say is that sleep is an important piece in weight management as well as emotional well-being, and wanted to transition now towards emotional well-being, because as we know, stress happens. And stress is it can be very damaging to our bodies. And as was pointed out earlier, some stress is good. I mean, and we need some stress in our lives. So you can think about it like building a muscle. In order to build the muscle, you need some stress. And then some stress, there are good stressors and bad stressors in our lives. We have happy events and sad events, but our body responds to it all in the same way. So this chronic high levels of stress are very damaging to our health. And we know kids with ID and autism, they experience stress. And that may be due to social situations that cause anxiety, academic situations, bullying. The bullying rates for kids with ID and autism is about 65 to 75% of kids, compared to 25 to about 35% of kids without disability. So it's pretty high, and that could be pretty stressful. There can be sensory challenges, change in routine, change in environment, sleep problems. So we need to be very aware of the stress that kids experience. It's very real. And I want to just take a moment to talk about parents and what the experience the parents experience. And I find this first statistic so troubling, that more than 80% of parents of children with autism and ID report feeling stressed beyond their limits. That's just unacceptable. We need to take action on this. And that can be, of course, kids experience challenging behaviors, and that can be very stressful. And even to think about sort of the course of a child's disability. Before they're diagnosed, parents they often are going from provider to provider trying to get answers. And sometimes providers that aren't that skilled or trained may put some blame on the parent, and the parent deals with that guilt. So until they can kind of get that diagnosis, understand what's going on, it can be very stressful. And that's why with a program like our LEND program, we focus a lot on that early and accurate diagnosis. Once a child is diagnosed, that parent may have to deal with just accepting that diagnosis or being in denial about that diagnosis and reframing the views and the dreams that they had for that child. And then after diagnosis, there's just the coordination of care and maybe changes in relationships between spouses. We know the divorce rate is higher in parents who have a child with a disability. There can be changes in relationships with friends and family. It can be very isolating. And there can be financial concerns. I mean, this is a very heavy slide. We know that when you have a child with a disability, often, usually the mother may have to stop working, so there can be just lower income, and then just the costs associated with services and programs. So a lot going on there. And this is a slide I show, I think anybody who has been on a plane has probably seen a version of this, and this idea of self-care and putting your own oxygen mask on first. And as caregivers, whether it's parents, siblings, whatever that role might be, a grandparent, it's often, or even as professionals, we often forget, we take care of all the others in our lives and we forget to do our own self-care. So this is just that reminder of putting your own oxygen mask on first. And the good news is, as damaging as stress can be and as stressful as life can be, stress is very responsive to simple interventions. And self-care is probably the most important thing that we can do to prevent and lower our stress. So I want to focus a little bit on mindfulness. And so mindfulness, there's a very robust body of literature on mindfulness and its benefits, including reducing stress, controlling anxiety, promoting emotional well-being, improved attention span, increased empathy, kindness, self-awareness, and helping with sleep and controlling pain. So there's a lot of bang for your buck with this. So what is mindfulness? I'll first tell you what it's not. It's not sitting and thinking about nothing or doing nothing and sitting with an empty mind. It's almost the opposite of that. It's sitting in a space, opening your mind to how your thoughts and feelings in the present moment without passing judgment. You don't say it's good or bad, you focus on that present moment. And I have an opportunity here just to tell you, and I'll base it, you'll tell me when my 5 minutes, just to do maybe, I thought I would do a couple practices with you to just demonstrate the power of mindfulness meditation. So deep breathing, I don't know if you're familiar with Andrew Weil. He's an integrative medicine physician, Harvard trained, and in the States he's considered basically the guru of integrative medicine and well-being. And he was asked if he had to boil down all of his wellness tips, down to one, what would it be? And he said it would be deep breathing and doing it properly. So in a moment, I'm going to combine some deep breathing with another technique that I'd like to show you. And that is the soles of the feet meditation. And what's really exciting about this one in particular is that there's research showing the benefits of use in kids with autism. And this meditation is designed, has the purpose and the effect of calming negative feelings. So it can be very beneficial just to have that in your back pocket. And it's also to use with oneself, or if you're working with somebody as a professional or as a parent or family member. So I have a video here, but I'm going to just do it for you, so you get it live. So I invite you to just sit comfortably in your chair. If you want to stand, well, I would sit for this one. You sit, just plant your feet on the ground. If you'd like, you can close your eyes. And I'm going to just take you through doing some deep breathing and teach you how Andrew Weil would have you do it. And I'm going to have you breathe in slowly through your nose and feel the air come in through your belly and expanding in your chest, and hold. And then exhale through your mouth. And again, breathing in through your nose, feeling your chest expand. And as you exhale through your mouth, just let your body relax. Feel your shoulders drop. Have you do a couple more deep breaths. And just feel the air, the sensation of the air coming in through your nose. Just pay attention to the sensations of breathing. And now I'd like you to shift your attention to your feet and just feel how your feet are planted on the ground. And think about your toes and how your toes feel. If you want, you can wiggle them a little bit. Do you have closed-toed shoes or open-toed? How's that feeling against your foot? And then focus on the bottom of your feet, your heel against the back of your shoe, the bottom of your foot touching the sole of the shoe, the sides of your feet. And now I'd like you to shift your attention back just to your whole body, your breathing, and how you're feeling. And I'll have you open your eyes when you're ready. So I don't know if that took a minute or 2 minutes. It doesn't take very long to do something like that. And there's so many tips and techniques out there, some that are very involved and some that you can do in 30 seconds. So the deep breathing you can do, what I like about that is you can do that anywhere. And you don't have to go to a mountaintop and sit, meditating in order to do these things. So they're very accessible. And then the other piece that I wanted to point out about the power of gratitude. And there's research showing there that gratitude can improve relationships, improve physical health, emotional health, your self-esteem, empathy. It can decrease aggression, again, improve sleep, and improve overall mental strength. So again, a lot of bang for the buck. So there's one technique that I wanted to share with you, and that's called 3 good things. And we know that memories are really tricky. So I know for me, when I have something not so positive happen, I'll ruminate on it, and it kind of sticks. And then the good memories are kind of like Teflon, they just slide right off. So this technique teaches your brain, kind of retrains the way you think. And with this particular activity, it is strongly encouraged that you write. There's something about writing that also has power to shift thinking. So it's the combination of writing, but this is, you can do journaling, of course, but this is just a quick and easy technique you can use. And basically, if you can do it twice a day in the morning and at bedtime, but if you're only going to do it once a day, it's strongly encouraged at bedtime because it can help with sleep and kind of help turn the brain off of all the hecticness of the day, and to identify 3 things, even if you can only come up with 1. Just if you can, I think it's best to come up with 3, but it's not that hard to do, and to write those down before you go to bed and really reflect on those, what happened that was good, that's going on that's good, and then your role in that positive thing that's going on. So I'm going to stop there. There's so much more we could talk about, but I really welcome this opportunity to kind of tee things up for our discussion, and very eager to see all the connections that we can look at as we think about the lifespan and what we can do at this point in time with children and families. So thank you very much.
Thank you, Sharon. I have to say I'm feeling very relaxed now and calm. So that's an added bonus of attending this conference, so thank you, Sharon. And I have to say just one small comment. I was really struck between the contiguity of Mary's talk earlier and Sharon's talk. And it just shows, really reinforces the importance of tackling these issues really early for both children and families, because they persist and they potentially get worse as we age across the lifespan. So I was quite taken by that. And again, these are all issues we can explore later in the workshop. So our next speaker is Dr. Arlene Mannion. And just a little background to her talk, Arlene's talk. Arlene is going to be presenting work that was carried out by an assisted fellow, Dr. Bernie Kirkpatrick, who can't be with us today, under my supervision. And in this work, we have developed assistive technology to deliver a sleep intervention. As we know, when a child is not sleeping, it doesn't just affect the child's health and well-being, but the entire family. As psychologists, behavioural psychologists, we have really good evidence and really good expertise in delivering sleep interventions. But the problem is they are incredibly intensive to deliver. And usually services don't have the resources to give to that intensity. So this project was really a work around this in terms of using assistive technology to bridge that gap. So just a few words about Arlene. Dr. Arlene Mannion is a postdoctoral researcher in my lab, and Arlene is a behavioural psychologist and a board-certified behaviour analyst. She holds a PhD in applied behaviour analysis, an MSc in applied behaviour analysis, and a BA in psychology. And Arlene's PhD was funded by the Inouye Galway Hardiman Scholarship, and she focused on gastrointestinal symptoms and sleep problems in children and adolescents with autism spectrum disorder.
So hi everybody, and as Geraldine was saying there, I'm presenting this on behalf of Bernie and all the great work she did as part of her assisted fellowship then in terms of sleep and developing a sleep app then under the supervision of Dr. Geraldine Leader. So with this presentation, it's all about how assistive technology, how AT can be used for children with autism, and how it can actually affect a child's sleep, a parent's sleep, but also their quality of life. So not looking at sleep in isolation, but looking at how it affects other areas of life. And it involved a multidisciplinary approach, so using sleep medicine, behavioural research, but also using computer science and engineering, and getting advice and feedback from parents of children with autism and also from service providers in designing an intervention then that is most likely to be as useful as possible. So what we know about sleep is that it has such an effect on our functioning. So we all know ourselves if we have a night where we didn't sleep well or where a child doesn't sleep well, how that's going to affect parents' sleep and their well-being the next day and their daytime functioning. But what we know is that for people with intellectual disability and autism, that they are a lot more likely to experience these kind of sleep problems. So, as Geraldine was saying, I focused my PhD research and continued my research then as a postdoctoral researcher here in ICANN on comorbidities and co-occurring disorders in autism. So specifically I focused on two different aspects then, on sleep problems and on gastrointestinal problems. And what we found in our research is that there is a real link between sleep and between behaviour problems, and also on emotional issues like anxiety and depression, that there's links there between sleep. So sleep is affecting all areas of life. We also found links between sleep problems in children with autism and then these children experiencing gastrointestinal symptoms. So Geraldine will be talking more about that tomorrow, about gastrointestinal symptoms and what they are, but they can be areas like constipation, diarrhea, abdominal pain. So there really is this link between sleep problems. And we found that up to 80% of children with autism are experiencing some type of sleep problem. And we also followed up as part of my PhD research on children over time. And that we found over a 2-year time period that the same children were still experiencing sleep problems. So often people would say, oh, well, maybe it's just when children are young and maybe they'll grow out of these sleep problems. But what we see again and again is that there's something that continue on throughout life. And we know then that sleep then has a big impact in all other areas of life, and research has shown this again and again. So if a child isn't sleeping, that's going to affect how they're learning in school the next day. It's going to affect their interactions with others. And often then there can be a lot more challenging behaviour and behaviour problems where a person isn't sleeping. So we know that across all different subtypes of autism and all levels of cognitive ability, so whether someone has a mild intellectual disability or more severe or profound intellectual disability, that they're still experiencing these sleep problems. And we know that there's links between having sleep problems then and having more severe symptoms of autism and also more difficulties with social interaction then. So often what we've seen in research is that where someone isn't sleeping, then in their next day's behaviour, that they can show more behavioural problems and more stereotype behaviours, more repetitive behaviours, and more difficulties in general. And we also know then that these sleep problems aren't affecting just the child, but they're affecting the parents, they're affecting the siblings, and they're affecting the entire family unit. Then that's going to have an impact on parents' quality of life and parents' stress levels as well. So there really is all these different links between how we sleep and how we function and how that affects us then. So in terms of insomnia, so not being able to sleep, sleep researchers would look at not being able to sleep and having insomnia in a number of different ways. So there's the more biological side of these sleep problems, which would involve things like if someone has circadian rhythm disorders. It could also be if there's any type of hormonal imbalance. And it could also focus on where a person has other conditions as well as their initial diagnosis. So it may be in terms of having anxiety, in terms of having attention deficit hyperactivity disorder. And we also know then in terms of insomnia that there's also medical causes for this sleep problem, where it could be where people have sleep apnea, where they have difficulties actually breathing and may actually stop breathing at times during the night. It can be where someone has epilepsy, that they're more likely then to actually have difficulties then around sleep. It can be, like I was saying, about gastrointestinal symptoms. So if someone has reflux, or if they have any kind of pains, any kind of gastro issues, that can affect their sleep. It can be if they have restless leg syndrome, where then they have this urge to actually move their legs during the night, that's waking them up and that's affecting their sleep. And it can be in relation to any kind of medications that they're on. So for this intervention that Bernie conducted, she more so focused on the behavioural aspect of sleep. So instead of looking at it only from a biological or from a medical perspective, but looking at what about sleep routines and what can we actually do from a behavioural perspective then in terms of sleep. So there can be many different causes of insomnia and not being able to sleep then, and they can be things like poor sleep hygiene. So your sleep hygiene really would be what your sleep habits are. Do you have a bedtime routine? Do you avoid screen time before going to bed? All these things that we often know about our sleep, but it's actually looking at what can be done about those. They can also be in relation to light, in relation to noise, any kind of environmental stimuli. It can also be in relation to increased caffeine, to having limited exercise, to having naps during the day, and it can be then even in terms of parent stress. So if a parent is stressed, it can be a lot more difficult to have a consistent sleep routine for their children. So in terms of the sleep intervention, it was developed then by Dr. Brian McGinley in collaboration with Geraldine and Bernie, and he focused then on developing an app based on the feedback from Geraldine and Bernie, and looking at how it can really focus on being as user-friendly and as parent-friendly as possible then. So in order to actually look at what kind of sleep problems people want addressed, focus groups then were conducted, and focusing on what are the main sleep problems. So rather than developing an app and thinking, oh, well, maybe this is what parents need, maybe this will be an issue, instead it was really focused on the parents actually leading the way in terms of what their children with autism were going through, what were the main problems. And then that became the development then of the app. So the first screen of the app then would display a number of choices of different sleep behaviours or different sleep interventions. So they could be delayed sleep onset, so trouble getting to sleep, where a child may sleep well when they get to sleep, but the difficulty is actually getting to sleep in the first place. It can be bedtime resistance, so not wanting to go to bed, not wanting to go to a bedroom, to not want to even engage in sleep in the first place. It could be early morning awaking. So for some families, it might be that they had a number of these behavioural issues and these sleep problems, but it was focused on, well, what was the main problem, and looking at addressing that main problem first of all. So early morning awakings, where a child is waking up very, very early in the morning, regardless of how much sleep they had the night before. It also then could be in relation to sleep maintenance, so waking multiple times a night, and then co-sleeping, so sleeping in parents' beds. Now with co-sleeping, people often ask about co-sleeping, and co-sleeping is only an issue if it's a problem for the family. So it's not that there is anything wrong with co-sleeping, but it's all in relation to what the families actually consider a problem. So if they don't have a problem with co-sleeping, then it isn't a problem to address. So once parents then actually picked which sleep problem they were focusing on, they then got brought to the second screen. So the second screen then would open up a screen about sleep hygiene routines. So this would involve having a routine in place, looking at have the lights been dimmed down? Has the child had a bedtime story? So all these different aspects of having a sleep routine. The third screen then would open on to relaxation techniques. So these could be breathing exercises, visualizations, and so that parents were doing these as well then with their children. And as parents were going through these steps, they were to actually tick boxes, that they were going through each of these steps, and they also had the option in the app to audio record. So if they wanted to say, that was a great night, that worked well, this didn't work well, they could also record that in the app. So they didn't have to take any notes then with that. The next aspect of the app then focused on social validity questions. So it was asking parents if they found this useful, was it easy to use, and really making it as user-friendly as possible. So that was one aspect of assistive technology that was used in the intervention. But the other aspect was actually using an objective measure of sleep. So this was done through a device, so a sleep device, so that you would wear on your wrist, and that way you could actually measure if a person is sleeping or not, so that you could measure if children were sleeping or not. Because it may be that if you're relying on diaries only, that's putting a lot of effort on parents to actually have to record what time their child went to sleep, how many times awake during the night. So then it gave another aspect of using technology then in this intervention. So for all the parents, whether they were in the treatment group or in the control group, they all received parent training sessions. And these then were based on a systematic review conducted by Bernie and by another assisted fellow, Julia, and supervised by Geraldine. So looking at really what was evidence-based practice in terms of training parents to teach their children how to sleep. So all parents then in the different groups, whether it was if they were receiving the intervention of the app or not, they received parent training. So in the treatment group, there were 9 families that completed the 6-week intervention. So it was using the app, using the sleep tracking device, and also using a sleep diary. And then they had a follow-up interview then of a month later, how they found the intervention. So then the control group, they received the sleep diary, they still had the sleep tracking device, but they didn't have the app. And it was after the intervention then they were offered the use of the app afterwards. So it was really a delayed wait list then in terms of that. So in the participants then, there was questions asked about whether siblings were also living at home as well, and if siblings were in a room together with them. So the 2 groups, the treatment group and the control group, so they were very similar in terms of actually matching. And then after the intervention, it was found that in terms of the parents reporting on their sleep, that there was a significant reduction then in the child's sleep problems. So using a questionnaire measure, they found that this difference was actually found. And the same way in terms of the parents' sleep. So there were significant differences in what parents reported over time. Then in terms of their quality of life, there was an improvement seen then in terms of children's quality of life. So not only was their sleep improving with the use of the app, those that were in the app conditioner, the treatment group, their quality of life actually improved as well. So in terms of the objective measures of sleep then, all the different sleep behaviours were actually evaluated. And you can see there then in terms of the night awakenings, so the treatment group then and the control group. So with the treatment group, so they're in the orange and the blue, so you can see then that there was a decrease in terms of the amount of times they actually woke during the night. There was also effects in terms of how long it took them to go to sleep. So across all different aspects of sleep, that there was significant differences there. So from one child then that now only took 30 minutes to fall asleep compared to it took an hour and a half before that, so 90 minutes beforehand. So that really what you're seeing is that there was differences in terms of all these sleep behaviours. Even in terms of bedtime resistance, of wanting to go to sleep, again there was significant improvements then in that children were sleeping better, and then children were actually sleeping longer at night, not having as many early morning awakenings. So across all different aspects of sleep. There was improvements as well in co-sleeping. So children were learning to soothe themselves to sleep as well, and had less reliance on co-sleeping and sleeping with their parents. So in terms of the usefulness, the results were very positive, and over 60% of parents were definitely finding the sleep app easy to use and convenient to use. And then even at follow-up interview, parents found this app very useful. They still were using it over longer periods of time. They felt confident about using it, and they really saw an effect in terms of their child's sleep. So in terms of future research, this has a lot of potential in terms of ease of use and convenience for families, and this does have a lot of potential. But I suppose what we need to see is more research conducted in larger groups and clinical trials that's actually evaluating a sleep app like this in terms of how useful that can actually be as a way of incorporating technology then for families of children with autism. So that's my presentation, so thank you very much.
So thank you very much, Arlene. And our final speaker in this session is Vivienne Finn, and I'm delighted to welcome Vivienne. And Vivienne is the coordinator of the school age disability team from the Daughters of Charity Support Service. So I think it's really important that, after these two talks, that we hear what it's really like on the front line in a service such as this. And Vivienne will talk about achievements and challenges. So Vivienne is coordinator, as I said, of the school age disability team. She is a senior speech and language therapist and has been in this role for 4 years. Vivienne has 20 years experience working as a speech and language therapist, and she was a senior SLT on the DOC early service team for 10 years. Vivienne has worked across primary care, child and adolescents, mental health and disability services, both in Ireland and Australia.
I'm going to keep my notes beside me because I jotted down some ideas that I'd taken from some of the talks from earlier today, and it's interesting to see so many links from both the ageing study and how we're seeing that in kind of our youth today as well. Unfortunately, saying that I have 20 years experience betrays my mental image of me being still 25. So I've started off with this image because I think that is one of our primary goals for all of us here today, both in services and in research, is our goal is inclusion. Inclusion for all our children and our adults in their everyday lives, their everyday services and their community that they live in. And so I'll start with this image and I'll finish with a similar image as well. So I want to give a little bit of context to the children's disability team that I coordinate within the Daughters of Charity. So I work in an area in Dublin Northwest where the Daughters of Charity, the Dublin service is based, but it's part of a wider area that covers all of North Dublin City and County, and that area is called CH09. And within that area, there are lots of different services, which is fantastic but can add to the stressful lives of parents. And we've already heard today that 80% of parents are experiencing stress that is beyond their limits. And sometimes some of that stress comes from being able to access services. So within our area we have primary care, which goes from 0 to 18, and that is all individual disciplines working with children who have lots of needs in different areas. We have our child and adolescent mental health services, which supports children who have a diagnosis of moderate to severe mental health issues. And then importantly for us, we have our intellectual disability services. We now have school-age disability teams that are attached to those intellectual disability services. We have HSE early intervention teams, and we have Beach Park, which is a specialist service for children with a diagnosis of autism who are attending autism units attached to mainstream schools. So there are lots of different services. So I want to kind of give the context. There was a huge programme of change coming for disability services. And it's called Progressing Children's Disability Services, which is a national programme of change. So traditionally, intellectual disability services, we would have provided supports to children who had a diagnosis of an intellectual disability. So all services have access criteria which defines what children we see, but that in itself creates a huge amount of barriers for parents if their children don't fit into those categories. So the vision for Progressing Children's Disability Services is that there will be a clear pathway for children with disabilities according to their need and not just their diagnosis. And that's a huge change for disability services in Ireland because we have always traditionally been diagnosis-led. So our own service traditionally would have been a service for children and adults who had a moderate, severe or profound intellectual disability. So going forward with this programme, it will be for children, for our children's services, it would be for children who've got complex needs arising from a disability, but they don't need to have a diagnosis to be able to access those services. The vision is also that effective teams will work in partnership with parents. And we've heard a lot about that need to involve parents and their children and young adults in their services and what they want from services. That all disability services will be delivered locally through network disability teams. That services will be based in the children's local area and that services will be equitable. We've been very fortunate in the Daughters of Charity in the area in Dublin North West that we've always provided an excellent service to children and their families who've got an intellectual disability. But go further across the city and that may change quite significantly where there are longer waiting lists for children who've got the same needs. So really the vision for Progressing Children's Disability Services is that there will be equity of access for all children. So that's just a little bit of the context from where we're working. So in CH09, while Reconfiguration is a national project, we still haven't fully reconfigured, but in 2015 there was a development of 4 interim teams, which was the first step in this. When Reconfiguration is completed, the Daughters of Charity will have 3 network areas that will cover all of Dublin 15 and Dublin 7, and these network disability teams will range for children from 0 to 18 who have complex needs arising from a disability. Dublin 15 and Dublin 7 is a hugely densely populated area that is growing. It's the biggest area of growth in North Dublin at this stage, with a wide range of socioeconomic classes. And unfortunately what we're seeing in our area as well is a huge degree of homelessness. And it would be interesting to see what the experience of homelessness is that higher for people who have children or family members with a disability versus the general population as well. So what will reconfiguration mean? Importantly for families, what it will mean is that their disability teams will be located in their local area. Currently, if you live in Dublin 15 or Dublin 7 and you experience a physical disability, you will have to travel across the city to Clontarf to get to the CRC, the Central Remedial Clinic. And hopefully that would change over time, that they would be able to access their services in their local area. So that children with complex need would be seen by their local network team, and that all our services will be team-based services. So all professions involved will be aware of what that child's needs are, what their goals are, and what their priorities are. And importantly, what that family's goals are for their child and for their own family as well. So for teams then, what will it mean for reconfiguration? It will mean that all people will be co-located together, which will encourage more interdisciplinary working, more skill sharing and more goal setting. An opportunity to expand their own clinical skills because they're going to be working with a much wider range of children with complex needs, and a possible change in line management, but we won't go into that today. So within the Daughters of Charity, we have a number of teams operating. So we have our own special school that has a clinical team attached to it. We have our mainstream team, which was established probably over 10 years ago now for children who are attending mainstream schools. And that's been a huge shift in the last 10 to 15 years in Ireland, that children are going to mainstream school and are managing well in mainstream school. But in order to do that, they need supports from teams and supports from those schools as well to do that. Within our own service, we have our Developmental Education Centre, which is for children who've got significantly complex medical needs with an intellectual disability as well. We have our own early services team, which supports children from 0 to 6, and I know there are a couple of my colleagues here today giving poster presentations on some of the great work that they're doing there. And then we have our school age disability team, which is the one that I coordinate, that was set up under the auspices of the Progressing Children's Disabilities model. So after reconfiguration, we hope that our children's services will look something like this. There will be specialist teams, but that we will have 3 network teams, making it much easier for parents to navigate the system. I have not always worked in Dublin. I used to work in County Meath, where when I left County Meath there were basically 2 services. There was the HSE and there was Enable Ireland. And I, coming to Dublin as a healthcare professional, found it extremely difficult to navigate the health services that were available within that area. And that was me who understood the system. So you can only imagine the stress that adds to families when they don't know where to go, when they don't know how to access services for their children, and that they feel they're constantly fighting for services. So our model of service is that it is family-centred. And we can see, and I think from one of the videos, in the life stories, someone said that my family is my life. And that is one of the reasons why our service has to be family-centred. We are based as interdisciplinary teams. So on our team, we are fortunate to have the full range. We have psychology, speech and language, occupational therapy, physiotherapy, and social work. And they all work together. We are goal orientated, so we are constantly looking to our families to set their goals for what they want to work on. And we are outcomes focused. And those outcomes are based both on outcomes for the child, but importantly outcomes for the family and how this works for them as well. We do have, currently, because we're not reconfigured, we do have access criteria, but they are very broad, so I won't go into a huge amount of detail on that. But our goal as the school age disability team within the Daughters of Charity is to support parents to help their child reach their full potential, to support child's development through providing appropriate interventions to achieve specified goals, to support their child in their school environment, and I'll talk a little bit more about that support a little bit later, and support parent and child in accessing local community activities, sports clubs, groups, holiday camps. And Professor Mary McCarran talked about physical inactivity, and this stems from childhood. I have been surprised as I meet all the parents how little activity, physical activity, their children may be undertaking. And we need to look at why that is. And I think we've mentioned today in Sharon's talk about the barriers to being able to access those programs. And that's a really important thing for us to look at what are the actual issues that are causing that and how, as services and as teams, we can support families in that. So we have become very proactive in linking our families and our children with local community groups because we want them to be included and integrated into the community that they're living in. So we do have an assessment process. I do tend to meet all the families first to kind of explain the service to them. We have an initial visit with the family to discuss their goals, and this is a really important stage of it. It gives parents the opportunity to discuss their concerns, their goals, what they want from a service, and what they would like their child to achieve. So the family are always included in indicating their priority needs and their goals for the interventions with the team. And sometimes they may vary from what we might think would be an appropriate goal for families. We do offer an initial team assessment, and that's been tweaked over a number of years. When we first started this model, it was very much based on family goals and what they wanted. But listening to our families, they wanted a mixture of both. So they wanted their clinical assessment so that they knew what goals they could be working on, and they wanted that piece from family as well. So we kind of listened to that and came up with a more robust assessment process. The individual family service plan, or the IFSP, is then agreed with the family, and this is where all the findings of the assessment, the initial visits and family priorities are formulated into goals and interventions that we'll target. The IFSP is really the cornerstone of what we do, that we refer back to all the time. And I think there needs to be that recognition that families and children are the service users, so they need to be able to define how that service will look as well. So this IFSP gives parents an opportunity to voice those priority goals. It's a written record of those goals and how we and the family will meet them and how that will be agreed. And we also look at including some outcome measures in that we can look at in a year or 18 months or whenever we regularly review them. So our interventions then, we are using this kind of tiered model. So our universal supports, our targeted supports, and our specific supports. So for us, some of our universal supports is parent training and information sessions offered across all of our pathways. I listened to some of what Sharon was saying about self-care, and we have offered a series of workshops where self-care has been part and parcel of those. And interestingly, it's probably the one that parents go to the least because they don't recognise their own needs in it. They just want to have services for their children. And I think as teams, it is up to us to support families in recognising that they need to be minded as well. So we need to figure out how we can support parents to recognise that as well. Some of the programmes that we offer are Early Bird, Parents Plus, Signet, Emotional Regulation is something I'll go into in a little bit more detail because it links into some of the sleep things that we were talking about earlier. And we offer a series of workshops for parents and lots of teacher training. So there are universal supports that we try and offer to as many people as possible. Our targeted interventions then come across all the disciplines. So we have been using Lego groups to work on social skill development, and there's a lot of research behind those. I suppose because we see a lot of children who have physical difficulties, we have been working a lot on movement groups and encouraging them to link in with their local community. Social skills is a huge area of need, particularly for children who've got a diagnosis of autism, and developing independent skills. So I won't go into a huge amount of detail as I see my time being put up there. So you'll see these slides later, so specialist interventions as well. So school support, and I think we need to recognise that school is a hugely challenging place for children with complex needs. It's challenging for parents to accommodate the needs of children, and it's a very overwhelming place for children who've got additional needs to be in. So our team will attend individual education plan meetings, we'll do classroom observations and offer specific strategies to support that child in accessing the curriculum. So this whole conference is really around transitions, and one of the biggest transitions for our children is moving from primary school to secondary school. I've recently been in secondary schools and it takes me back to my own time, a long time ago now. But you remember how overwhelming a place a secondary school is. It's extremely busy. If you think of a 12-year-old child, any 12-year-old child going into school, it's an extremely busy place. There are very tall young men of 18 who are still in school perhaps. They're very, busy corridors, haven't access lockers that all look the same, having to move from classroom to classroom every 40 minutes, having to follow a schedule that may not be a visual schedule for you to follow to be able to move from class to class, remembering all your books. All of those small things are hugely challenging for our children. So we do offer transition programmes. We offer a workshop for parents to be able to identify what school may be appropriate for their child. We facilitate meetings between the primary school and their targeted secondary school. And this workshop gives parents a real opportunity to link in with other families who may be going through that as well. So some of our successes, because I did term my presentation, our successes and challenges. We have over the last 4 years provided and are still providing therapeutic interventions to over 300 children with complex needs. We develop very strong links with our local schools. We are co-working with some of the other services like child and adolescent mental health and primary care. We've developed and delivered very effective parent and training programmes, and we've piloted an autism acceptance project in schools consisting of a teacher model and 3 student models. So I'm just going to go into a little bit more detail on that. I'll flip through some of these. So this Autism Awareness and Acceptance pilot project, we ran it in May and we intend to roll it out to more schools. And we have 4 parts to that project. So there's a teacher training module, which gives them information on what it is to experience autism, how they can support a child within their classroom using some of the techniques from our emotional regulation training. And then we offered 3 modules to children from 1st class all the way through to 6th class in primary schools. So we looked at our sensory system, and the children got an opportunity to look at some videos to experience what it was like to have any sensory difficulties, and then got to make up a little toolbox of their own of sensory activities that would be calming for them and for children with autism as well, to really experience that. We had another session called Walk in My Shoes, where again there was experience of what it's like to experience autism, how they could become a good friend to someone with autism, and thinking up of a toolbox of how they could include those children in their school environment. But the most worthwhile part of this was the personal experience of autism. So one of our young service users, agreed to come along and do a question and answer service within those classrooms and present himself from first class all the way through to sixth class to some of his peers. He'd had a very negative experience of school and had already changed schools once, so this was a very daunting experience for him. He was well supported by the team, so he got a view of the questions beforehand and was able to answer it. But he took to it like a duck to water and was walking around the classrooms telling people what it was like to experience an autism. So some of the outcomes from that, it was really successful in raising awareness of autism, but really what we want to have is acceptance and inclusion. But some of the children, what they said was, even though it works differently doesn't mean it's wrong, and autism makes you see the world differently. So this is something that we would really like to continue as part of our programme, to roll out this project to lots of schools in our area because they're crying out for information and for training. And again, thinking of the physical disability, the physical limitations that some of our families can experience, linking with our local disability sports officer in Fingal County Council to see how we can encourage more involvement in local community groups and how we can bridge that for some of our children. There are challenges, I'm probably going to view them as opportunities for development rather than being negative about it. But the number of children requiring our service far outweighs the capacity currently. Our waiting list is growing. Discharge numbers are low because the children still present with complex needs that require the support of a disability team. Caseload numbers are high, and parents still have expectations of always having individual therapies. But again, I suppose that for us as a team and a service is to be able to provide that wide range of support and to encourage parents to view therapy maybe a little bit differently. Complex issues such as school breakdown, which is unfortunately a huge area of need for all children across all our teams within the Daughters of Charity. School breakdown within mainstream requires intensive support to maintain that placement. We are seeing lots of mental health issues and anxiety issues amongst our young children on our particular team, and it's interesting that we're still seeing those in the ageing population as well, and perhaps with more support at this stage. So having those links with our child and adolescent community health service would be really useful for our teams as well, for them to be able to access that support. So where to next? I started with an inclusion image, and I'll finish with an inclusion image as well. So these are all the things that we want to achieve, with ultimately inclusion being the end goal for all of us.
I just want to quickly thank Vivienne, and I think that was an excellent note to finish this session on, because it brings up loads of issues that we can pick up in the workshop in terms of setting the agenda, and on the word that Vivienne finished with, that we can promote inclusion, and how we in DOCTRID can help in that mission in promoting inclusion for school children.